Physiologist at CIMS Hospital, Ahmedabad, and with me is Dr. Hiren Kevadia. He is my associate, also a qualified electrophysiologist. Um, we are both going to be on this presentation. Dr. Kritika will give the additional information, and I'll talk about preamble to the actual recording of the lectures on syncope. Kritika, can you take over?
Sure. Thank you, Dr. Nayak. So today, good evening, everyone. We have with us Dr. Ajay Nayak, who is a renowned cardiac electrophysiologist and who is the director of Care Institute of Medical Sciences of the Heart Failure Device Division. He's also the principal investigator for multinational drug and device clinical trials. He's the national and international faculty for cardiac electrophysiology and the vice president of IHRS, which is the Indian Heart Rhythm Society. He's also the past president of Indian Society of Electrocardiology. It is a great pleasure to have you here, Dr. Nayak. Thank you for joining in.
Thank you.
Moving forward, we also have with us Dr. Hiren, who is again a cardiac electrophysiologist. He works at the Care Institute of Medical Sciences, Ahmedabad. He's the associate member of Indian Heart Rhythm Society and is a member of Asia Pacific Heart Rhythm Society. Thank you, Dr. Hiren, for joining us again.
Thank you, Kritika. So
Yeah.
today's session is going to be on syncope. Syncope, as all of you know, it's a very common and disabling symptom. It occurs at any age. It can occur in early childhood. It can go through adolescence, in adulthood, and even in elderly patients. In the vast majority, pre-syncope and syncope are not life-threatening, but in some patients, it can be a harbinger of sudden cardiac death. So when a patient presents with pre-syncope or syncope, we need to get to the bottom of the problem. What is the etiology of the syncope? If it's a fairly common problem like a vasovagal syncope, it can just often be treated or kept under control with behavioral changes, etc. But it could also belie an underlying structural heart disease, underlying uh, electrical problems of the heart, and that could cause sudden cardiac death. So today's session is split into two lectures. One is on new guidelines for management and investigations in syncope. And the second session is a case discussion. What is causing syncope in these patients? So let's start with the first recording. Please put in your questions in the chat box. We'll collate those and we'll address those at the end of the session. Stay safe in these challenging times. Take care of yourself and your family and significant others. Hiren, you want to say hello and then we can start the session, Kritika?
Yeah, sir. Thank you. Hello, everyone. We'll not waste our time and we'll just go on our syncope lecture.
So I've made 10 points and we'll discuss those that are clinically relevant, and we'll try to make it a little interesting if possible. These are new syncope guidelines which have come out in 2018 from the ESC. First is the definition. Syncope is a transient loss of consciousness due to transient global cerebral hypoperfusion characterized by, this is important, rapid onset, short duration, and spontaneous complete recovery. So you don't need to give injections, you don't need to give a shock to the patient for recovery. So rapid onset, short duration, spontaneous complete recovery. The transient loss of consciousness can occur due to a variety of reasons. There may be loss of awareness, there may be amnesia, abnormal motor control, loss of responsiveness. But if it is a syncope, if there is presence of features specific for reflex, orthostatic hypotension, or cardiac syncope, and absence of features specific for other forms of loss of consciousness. So this is important. It has to be the history, etc. should point towards that. Like I said, transient loss of consciousness, it could be due to a variety of reasons. It could be traumatic, head trauma can cause amnesia, etc., etc. Non-traumatic is what we are talking about. And syncope, epileptic seizures, it could be psychogenic or certain vascular or rare causes. And in syncope, mainly we talk about three things: reflex syncope, orthostatic hypertension, and cardiac cause of syncope. Whenever we are talking about reflex syncope or neurally mediated syncope, the most common is vasovagal syncope, orthostatic vasovagal syncope. It is precipitated by fear, pain, uh, looking at a needle or some instrumentation, or looking at blood, or it's situational. It could be due to when person goes to the bathroom in the night at 2 o'clock to pass urine and gets a syncope. So mixture is in syncope, or swallowing, coughing, loud laugh, vomiting, that can cause syncope. These are all situational syncopes. Hypersensitive keratitis syndrome, I showed a case in the morning, and certain other atypical presentations. So reflex mediated syncope, and this is an example. The patient is a normal person, but passed out during severe vomiting, and this was recorded. This was a transient AV block. It's intense vagal stimulation which causes this. So reflex mediated syncope. Second is orthostatic hypertension. Most common is, as we know, drug-induced orthostatic hypertension, especially in the elderly. Vasodilators, diuretics, due to volume depletion, due to bleeding, diarrhea, vomiting, or less common causes like autonomic failure. We don't see them very often. Cardiac cause of syncope, of course, is very important. Arrhythmia is the primary cause. It could be due to bradycardia, sinus node or AV node dysfunction, or tachycardia, both supraventricular and ventricular tachycardia. And very ominous are structural heart disease causing syncope. So wherever there is obstruction in any form, aortic stenosis, hypertrophic cardiomyopathy, pulmonary embolism, all those can cause these problems. So mass like this huge myxoma can cause. And there are certain LOCs, loss of consciousness, which may be incorrectly diagnosed as syncope. Some kind of seizures, falls without transient loss of consciousness, hemorrhage, TIAs, subclavian steel, metabolic disorders, intoxication, coma. So these need to be ruled out. So whenever we talk about these, cardiac syncope forms a part, reflex syncope, and orthostatic hypertension due to variety of causes can give rise to it. So third point is risk stratification. We need to identify the high risk patients. If there is new onset of chest discomfort, breathlessness, abdominal pain, or headache associated with the syncope. So when we are talking about the syncopal event itself, if these things are associated with it, it is high risk. Syncope during exertion, or when syncope occurs when the patient is lying down in bed. Sudden onset palpitations, if associated and followed by this is high risk patient. In the past medical history, if there is severe structural disease, coronary artery disease, LV dysfunction, heart failure, previous MI, these are patients with high risk. Physical exam. On physical exam, if the blood pressure is low, less than 90, if there is some suggestion of GI bleed, persistent bradycardia, or when you auscultate, there is a loud systolic murmur, that is again ominous. This is high risk because there could be aortic stenosis or HCM. If you look at the ECG, high risk red flags, if there is active ischemia going on, if there is AV block, atrial fibrillation with slow ventricular rate, or sinus bradycardia less than 40 beats per minute. QRS is wide. If there are Q waves suggestive of previous coronary artery disease or HCM, if there is VT, and if the patient is on device or you suspect Brugada, long QT, etc. So these are all high risk. What do you do when the patient comes to the emergency room or comes to you with syncope? The high risk features, and if the patient has coexisting disease, then it is better to admit the patient. If there is an injury associated with the syncope, admit the patient and observe. If you feel that the patient needs to be urgently evaluated, or you need to start a treatment which cannot be done in the emergency room or daycare, admit, like doing an echo, stress test, TP study, anything else, need for treatment of syncope, these patients should be admitted. In our part of the world, we don't have any syncope unit as such, but there they can observe the patients with for some time in the syncope unit. But in our case, it is better to err on the safer side. And just like I said, the high risk features which were present earlier in the syncopal event, past history, ECG, physical exam, and if the patient has any of these issues, then it is better to admit and investigate the patient. Diagnostic criteria with initial evaluation. So this is point number 4. For reflex syncope, vasovagal syncope is highly probable if syncope is precipitated by pain, fear, standing, and associated with a typical prodrome. The patient is pale, is perspiring, there is nausea, or they throw up, or there is vomiting. So this will go in favor of a vasovagal syncope. Situational syncope, if it occurs during specific trigger, severe cough, vomiting, then it can be situational syncope. With orthostatic hypertension, when it is associated with standing, and there is blood pressure drop which is documented, this is will go in favor of orthostatic hypertension reflex syncope. For cardiac syncope, it is likely arrhythmic syncope is probable if there is persistent sinus brady, rate less than 40, or there are more than 3 seconds pauses in the awake state. If there is second or third degree AV block, on an ECG, if you see alternating left and right bundle branch block, or if there is documented tachycardia, then that is likely to be cardiac syncope. If there is associated acute ischemia, or when you do an echo and you find a myxoma, thrombus, aortic stenosis, then that will obviously go in favor of a cardiac syncope. How to evaluate these patients? What is the diagnostic strategy? Like I said in the morning, history, physical exam, very important. You may get to the diagnosis right away, but after that, if it is innocuous and you don't get a diagnosis straight away there, and you feel that cardiac syncope is likely, you do a echo, ECG monitoring, external or implantable loop recorder, EP study, stress test, angio, depending on what you find in history. If cardiac syncope is unlikely as per your history, then you would go for autonomic tests. What are these autonomic tests? Make the patient stand, look at the blood pressure, look for orthostatic fall of blood pressure, Valsalva maneuver, deep breathing, cough, carotid sinus massage, but do it with in elderly people, be a little careful while doing it. Have a ECG monitoring going on all at the same time. Head up tilt test or ambulatory blood pressure monitoring. We don't do everything in all patients, but your history will guide what should be done for each patient. So this is an example. This slide I've been showing for 20 years now. I was looking quite young at that point of time. So this is a head up tilt test which is being done, and during the tilt test, there is sinus bradycardia, the patient has pre-syncopal symptoms, then we bring the table back down and the patient's symptoms recover. EP study, what is the indication? In patients with syncope, previous MI, or other scar-related conditions like dilated cardiomyopathy, hypertrophic cardiomyopathy. EP study is indicated when syncope remains unexplained after the non-invasive evaluation. So you've done the echo, you've done ELR, you've done other kind of monitoring, you still don't know what is happening to the patient. In these patients with structural heart disease, you should do an EP study. In patients with unexplained syncope and bifascicular block, so right bundle left axis or left bundle left axis, we should do an EP study to find the HV interval. It is prolonged, then probably the patient is getting intermittent AV block. If there is LV dysfunction, look for inducible ventricular tachycardia. And induction of SVT or VT with hypertension, then you can correlate. Unexplained high risk of sudden cardiac death like coronary artery disease, dilated cardiomyopathy, hypertrophic cardiomyopathy, we should all be aware of that. What about treatment of syncope? In reflex syncope, it is very straightforward. Education, lifestyle measures, lots of water, improving exercises, improving the muscular coordination, that all helps in reducing the incidence of the reflex syncope. In some patients, we can give fludrocortisone or midodrine. But but we generally give it for a few weeks or months and then generally stop the medication. If necessary, do loop recording to establish the diagnosis. Cardiac pacing is hardly ever done for reflex syncope. Explanation of diagnosis, provision of reassurance, explanation of risk of recurrence, avoidance of triggers and situations are indicated in all patients. I especially tell my patients that in summer, drink lots of water, don't go out between 10 and 5 in the hot Ahmedabad summers. If you need to go out, drink lots of water, wear caps. In airplane travel, avoid alcohol, drink lots of water because it's a very dehydrating, dry atmosphere. So those education is very important. For orthostatic hypertension, again, education, lifestyle measures, adequate hydration and salt intake if it is safe for the patient. That helps. Counter pressure maneuvers, so postural exercises before standing, or compression garments. These are the TED stockings which can be given to patients. That also helps prevent this. Adequate hydration and salt is important. Treatment of some syncope for cardiac arrhythmias. If there is documented bradycardia, we have to take care of by pacing. If bifascicular block, again, EP study and pacing if required. So this is an example of a patient with sick sinus syndrome, severe sinus bradycardia, and sinus pauses are seen. So this is sick sinus syndrome. This is an example of implantable loop recorder, which is put in a patient just below the skin. It will record for 2 to 3 years. Nowadays, the loop recorders are even thinner, so you don't need any incision. It is just injected like a pen below the skin on the chest. Treatment of syncope in cardiac arrhythmia, if established bradycardia AV block, will be pacemaker. If it is going to be ventricular tachycardia, then the patient will require ICD or CRT. If cardiac SVT causing syncope, catheter ablation is the treatment of choice. For ventricular tachycardia, catheter ablation or ICD, depending on the underlying disease, would be the treatment of choice. All these guidelines are actually free and they are in the ESC pocket guidelines. There is an app also which you can get and they are available. But this is broadly the picture, broadly the idea about how we tackle syncope. History, clinical evaluation, physical examination is the most important thing. And that will determine how and which direction you want to investigate these patients, how aggressive you want to be in terms of investigation and to get to the bottom of the problem, and how aggressively you want to treat it, either by lifestyle measures, education, behavioral changes, or by invasive methods, ablations, or by implantation of devices like pacemaker or CRT or ICD, depending on the individual requirement. Syncope is always a conundrum. We always wonder. And we need to get to the bottom of the problem because syncope can herald sudden cardiac death. Now, syncope is a transient loss of consciousness due to transient global cerebral hypoperfusion, characterized by a rapid onset, short duration, and spontaneous complete recovery. This is elderly gentleman. He had come from abroad to Ahmedabad, 79-year-old. He had episodes of syncope. EF was 35%. He had previously been treated for CA esophagus. And ECG showed a relative slight sinus bradycardia, and there was left bundle branch block pattern. So what are the possibilities here? One is, of course, the bradycardia, sinus bradycardia. There may be sick sinus syndrome causing transient brady and then syncope. Since the patient has left bundle branch block, there could be AV block, which might be happening. Patient's EF is 35%, possibility of ventricular tachycardia. In elderly people, we always think of hypersensitive carotid sinus syndrome. And elderly people, orthostatic hypertension is also a real possibility. Now, syncope algorithm, there are complicated algorithms, but this is very simple. If patient presents with syncope of unknown origin, history physical exam is very important, and get an ECG. Some diagnosis will be suspected right away. There could be a loud murmur of aortic stenosis, and you could do specific testing and treatment for that. In some patients, the diagnosis is established, there's complete heart block. and right away you can go for specific therapy. In 60%, two-thirds of the patient, the diagnosis is still unknown. So the next investigation will be an echocardiogram. If the echo is normal, then you can do a head-up tilt test. And generally, is normal. If normal, if there is LV dysfunction, structural heart disease, then you need to and electrophysiology study is the next modern to get to the bottom of the problem. So this patient had left bundle branch block, EF 35%. So we did a EP study for this patient. And right away, when I put in these catheters into the heart, this is in the right atrium, this is in the bundle of his region, the heart is enlarged, there is cardiomegaly, and I could see that the HV interval is prolonged. And when we do provocative stimulation, I could see there was an intra-his conduction block. This is something we all should be aware of. This is represents the activation from atrium to the AV node, and HV from the his to the ventricle. And in this patient on atrial extrastipulus, there is H1, H2 prolongation, this intra-his conduction delay. So that it is highly possible that this patient was getting a AV block or paroxysmal AV block or intermittent AV block. EF was 35%. We always need to check whether the patient gets ventricular tachycardia. So we stimulated the ventricle and stimulated fairly aggressively, but even despite that, no VT could be induced. Interestingly, when you stop stimulating, there is a long pause here. So there, and the patient started getting symptoms again. I did carotid sinus massage for this patient. Of course, you need to rule out a carotid bruit and any other issue. Carotid sinus massage, there were prolonged pauses. And again, the patient started getting symptoms there. So there were two real reasons that this patient was getting the problem. One is the hypersensitive carotid sinus syndrome, relative sinus bradycardia, but more ominous is the intra-his conduction block. So the patient may be getting intermittent AV block. We need to address all of these. So in elderly people with hypersensitive carotid sinus syndrome, apart from the behavioral changes, more fluid, the real treatment is permanent pacemaker implantation. So pacemaker is important for the intra-his conduction block, AV block. We need to implant a pacemaker. If you put a ventricular-based pacemaker, that will take care of bradycardia, but we would lose the atrial control. So we need to put a dual chamber pacemaker. That would not help his LV dysfunction. He had a EF of 35%. So then the option was putting in a CRT. So he has one lead in the RA, second is in the RV, and third is in the LV region. CRT was implanted, the patient's symptoms disappeared, and at a follow-up of 3 months, EF was 50%. So we have addressed most of these issues. We did not induce any VT on the EP study, and with improvement of LV function to 50% in a patient of dilated cardiomyopathy, there are very less chances that he would get ventricular tachycardia, if at all, in the future, now that the EF has improved. So we did a therapy to combat all possibilities for these patients. There are 3 slides that you should be aware of. Prognosis in syncope is dependent on etiology. For a non-cardiac cause of syncope, the prognosis is fairly okay. At end of 5 years, mortality is 30%. But if you think of a cardiac cause of syncope, cardiac arrhythmia, structural heart disease, mortality is 50% at the end of 5 years. And 30% sudden cardiac death at end of 5 years. Whereas in non-cardiac syncope, sudden cardiac death is rare. So this is very, very important. When we evaluate a patient for syncope, the history is most important. For if it is a young patient, frequent episodes, the patient gets premonitory symptoms like nausea or blurred vision. During the event, the patient is pallor or has pallor or is perspiring, it's more likely to be neurocardiogenic syncope. Cardiac arrhythmias, generally elderly people, some history of structural heart disease, previous MI, shorter duration of premonitory symptoms, and the patients are blue, not pale, may have seizure activity. Seizures, neurological seizures are seen in much younger people. There may be aura. If it is syncope is precipitated after sudden unexpected pain, it's more likely to be vasovagal. After swallowing, coughing, loud laugh, it's likely to be situational syncope. These are reflex syncopes. With neuralgia, severe pain that can cause bradycardia, vasodepressor reaction. Again, this is reflex form of syncope. On standing, BP drops, patients will get orthostatic hypertension, patients will get syncope. Prolonged standing at attention, this is seen in vasovagal syncope. The common faint, this is the soldier's faint. This is orthostatic hypertension or vasovagal syncope, which we often see in medical students who are in rounds for a long time and they get dizzy and fall down. So that is a routine form of vasovagal or neurocardiogenic syncope. Well-trained athlete after exertion, again, these are neurally mediated syncopes. On changing position from supine to sitting up or from changing from one decubitus to other position, atrial myxoma or thrombus can give rise to syncope. Syncope with exertion is a very ominous thing because that signifies cardiac obstruction in some form, aortic stenosis, mitral stenosis, pulmonary hypertension, pulmonary embolism, hypertrophic cardiomyopathy, or CAD in some form. Head rotations, wearing a tight collar, hypersensitive carotid sinus syncope, and TIA, there may be other issues. Just quickly through another case, 42-year-old gentleman, repeated episodes of syncope, repeated episodes of palpitations. On one such episode, this ECG has been recorded. Irregular tachycardia. So it's tachycardia, irregular, wide complex. There is varying degrees of pre-excitation and secondary STT changes. So this patient, immediately, what do we need to do for this patient? This is fast, broad, irregular. What do you suspect is happening here? It's atrial fibrillation with WPW syndrome. Atrial fibrillation, pre-excited tachycardia. How to terminate this? Verapamil, diltiazem, adenosine, digoxin, ivabradine. None of these drugs are safe in this kind of problem. What we need to do is cardiovert this patient or give IV amiodarone and be ready to cardiovert this patient. So cardioversion was done, and underlying you can see there are delta waves which are present. So the patient had WPW syndrome. This is a life-threatening problem because atrial fibrillation, pre-excited tachycardia, very fast ventricular rates can degenerate to ventricular fibrillation, and patient can have sudden cardiac death. So in the EP study, I could induce varying types of arrhythmias, pre-excited tachycardia, orthodromic AVRT. We introduced catheters, look at where this accessory pathway is. The patient had a pathway. This is the tricuspid annulus, mitral annulus. This was in the posteroseptal region. We look at the electrical signals, deliver radio frequency energy, and this point of time, the accessory pathway is ablated and patient's problem is cured. So with one procedure, this life-threatening problem has been cured, and this patient will not even require medications in his entire life. There are various testings we do after that to make sure the patient is not having any other issues. And at 6 months follow-up, the patient was completely asymptomatic, no pre-syncope, syncope, and no palpitations. So prognosis of syncope, like I said, it depends on etiology. Cardiac cause of syncope has very dismal prognosis. You need to get to the bottom of the problem. Cardiac cause of syncope may herald grave prognosis. Clinical evaluation is most important. History and a detailed history of every single episode that the patient had will lead you to the problem, to the solution. Investigations have to be judicious and along a logical train of thought. You cannot do all investigations in all patients. So you have to have an algorithm in your mind how to take care of these patients. Therapy can vary from simple behavioral changes like a neurocardiogenic or vasovagal syncope to invasive and interventional management like in these patients of arrhythmias. Thank you very much.
Hi, so I hope everybody enjoyed these two presentations. There are a lot of questions. I will go through each one of them. I'll try to address some, and Hiren, maybe you can address some of these.
Yes,
So,
sir.
if a patient gets syncope, what is the immediate remedy available? Suppose it's a young lady who's gone for shopping. It's extremely hot in the summer, and in the shop she gets dizzy and she falls down. That's or she's feeling as if she's going to fall down, or she actually falls down. Hiren, how would you take care of that?
Yeah, so most likely such syncopes may be like vasovagal syncopes. So once we notice that somebody has syncope, we should immediately make the person completely lie down. We should not make him stand or make him sit. It's better to make him lie down, just check the pulse, and like if the person is medico or paramedico, he can check the pulses. Otherwise, the best thing is to raise the legs, because most of the time this type of the patient had syncope because of the low blood pressure, and if we raise the leg, immediately the blood circulation to the brain will be restored, and within a 2-3 minutes patient will regain the consciousness most of the time. And by that time somebody should call the emergency health services for the further transport and management. But the first remedy will be, don't, like when the patient is unconscious, don't give anything in the mouth like people used to give water or something. The best thing is to make the person lie down, wait for some time, raise the legs, and patient will be conscious within 2-3 minutes.
Yeah, absolutely. That was perfect, Hiren.
So
Next
that is
question
like,
is, yeah,
yeah. So yes, sir. So that
yeah,
is
go
for
ahead.
the like
You're saying
most common cause, like vasovagal syncope. But we don't know. Sometimes patient may be having some cardiac problem, and patient may be actually arrhythmia and the syncope. So in that case, suppose if we think that patient is having arrhythmias, so first thing is to find out the automated external defibrillator if it is available in the mall or in the railway station. Nowadays all the public places is containing the automatic external defibrillator also. So those patients who had syncope because of cardiac cause or ventricular arrhythmias, maybe the urgent defibrillation is one of the treatment modality.
absolutely. So there's another question: how syncope differs from transitional loss of senses or loss of consciousness. Actually, I had showed it in one of the slides. Transient loss of consciousness could be due to a variety of reasons. It could be vasovagal syncope. It could be a cardiac cause of syncope, which is causing this. It could be a head trauma, which can cause loss of consciousness. It could be a neurological cause. So transient loss of consciousness could be due to a variety of things, and history and examination would probably lead you to which way the patient should be investigated further. A very interesting question has come up. How long should you wait for a CT scan of brain? Hiren, I always say this that when we get patients of syncope for evaluation, more often than not, they are already having a one CT scan, a brain MRI, and a EEG, which are all three investigations, and probably a carotid Doppler is also done. So all four investigations are normal. So how would you decide whether the patient should be investigated neurologically or the patient shouldn't be investigated in some other way to look for, say, vasovagal or neurocardiogenic syncope or cardiac syncope?
Yeah.
Could you? Yeah.
So suppose if the patient comes to us with the history of transient loss of consciousness, and especially on examination, if the hemodynamics are stable, like pulse is normal, blood pressure is normal, but we are able to find out that patient has some focal neurological deficit, or in form of either a weakness of one side of the arm or leg, or maybe having sometimes slurring of speech, or a patient is having a history of maybe neurological illness in the past, or if the patient has involuntary passage of the bowel or bladder, or patient is having tongue bite. So if any history which suggests that patient is having possibly neurological reason, in that case we may go for urgent CT scan. But if the patient has regained consciousness completely and there is no focal neurological deficit at all, and there are no other features suggestive of seizure type of problem, and then in that case CT scan may not be needed urgently.
Yeah, absolutely right. And there is one dictum that if your clinical evaluation does not suggest a neurological cause, it's very unlikely that any neurological investigation is going to bring up the solution. So if you don't hear a bruit, if there's no FND, no focal neurological deficit, it's unlikely that the carotid Doppler or a CT scan or MRI will bring up any positive finding. So your clinical evaluation is very important. In fact, when we say evaluation of syncope is going to be history, and then physical examination, and then other investigations. So history is the most important. Okay, let me go to the next question. There's a question on what guideline is recommended for proper diagnosis and management of syncope. So my first presentation, I actually took you through various points of there are obviously guidelines come up periodically. This is the latest guideline which has come. Often the guidelines run in 30, 40, 50 pages. So this was concise. And it's a very, you can follow these guidelines. They are in the Pocket app and they are available everywhere. That's an interesting question which has come up. What guidelines should be followed to manage syncope associated with carotid sinus syndrome? And the case I presented actually had the patient had hypersensitive carotid sinus syndrome. Now, in these cases, this problem generally occurs in the elderly. Patient is beyond 70, 75 years of age, and when the patient has you've diagnosed hypersensitive carotid sinus syndrome, this condition is rather difficult to manage. It's not going to respond to drugs. You have to explain to the patient and family that in case the patient needs to get up and go to the bathroom, especially in the night, they need to wake somebody up, they need to take somebody's support. uh, you have to be very careful with hypersensitive carotid sinus syndrome. And often the treatment is going to be a pacemaker implantation. That is generally required for this. Very practical question. How to manage syncope by family physician? Hiren, why don't you tackle this? What should a family physician do and when should he refer the patient to you?
Yeah, so I think most of the time family physician maybe either in a peripheral center or he may be in the city also, but the most important part from the family physician point of view is the history and clinical examination, and history to rule out the cause, maybe whether it is a vasovagal syncope or orthostatic hypotension, which is somewhat benign, versus cardiac cause of the syncope, especially the exertional syncope. If the patient tells that patient had a syncope while doing some exertion or some exercise, so from that suggests that patient might be having cardiac cause of syncope. This is from history point of view. But and then from examination point of view, pulse examination, blood pressure examination, and cardiac examination and carotid auscultation. So these are the few examination points where we can pick up the patients of syncope where there is a cardiac cause like bradyarrhythmia or tachyarrhythmia or carotid stenosis where there is a carotid bruit, or there may be a systolic murmur on the auscultation which may suggest that the patient has outflow obstruction, either aortic stenosis or hypertrophic obstructive cardiomyopathy. So, on history and physical examination, the most important part from the physician point of view is to identify the high risk patients, those where the cardiac cause of syncope is there. That patient should be referred on an immediate basis. And most of the time now ECG is available with the physician. So, if the ECG is done and ECG is showing some significant abnormality in form of sinus bradycardia or arrhythmia in form of SVT or VT, or some type of AV block. So these are the patients, or LVH or something on ECG. These are the patients which should be referred immediately, if possible. Rest of the patients where there was a simple routine syncope which has recovered completely, and clinical examination is completely normal, cardiac examination is normal, ECG is not showing significant abnormality. And if the history tells that it's not a cardiac cause of syncope, more likely it is orthostatic or vasovagal syncope. And if it is first episode of syncope, a physician can just reassure the patient and do the maybe medical management only. He may not need to refer. But if there are recurrent syncopes, or if it is cardiac cause of syncope, patient should be referred immediately. So that is the, I think, main function, main like contribution from the physician is to find out high risk patients.
Absolutely, you've outlined it very well, Hiren, and that was excellent. On your history, if it is a young person with a precipitating factor, being out in the hot summer, relatively dehydrated, or a school child who's during assembly falls down and recovers within 1 or 2 minutes and no post symptoms, this is most likely to be vasovagal and they are treated conservatively. However, if it doesn't fit into this kind of scenario, older patient with previous myocardial infarction, diabetic, hypertensive, patient on medications, where anything does not fit into this first picture, these patients should be investigated. And recurrent syncope should be definitely investigated, even if it is in a young person and it sounds like vasovagal syncope, because we don't want to miss out on a major life-threatening problem. Excellent. One question is which conditions may be the underlying cause of orthostatic syncope? So this is fairly common in the elderly age group. Patients may be on diuretics, or patient may be on other antihypertensive medications, or the patient has had an episode of loose motions, diarrhea, or the patient has had some unknown or unrecognized blood loss. So these are the circumstances which can cause orthostatic syncope. And it should be, again, you need to investigate, find out the problem, and address the issue. Very general question. I don't think we have the answer to this. What is the incidence and mortality rate of syncope in India, especially in pediatric and geriatric patients? Uh, Unfortunately, I don't think we have data of anything in India, especially medical issues like this. But syncope is common. It is less common in infancy. If it is if loss of consciousness occurs in infancy or early pediatric age group, it has to be investigated very rigorously. Otherwise, syncope is very common. Even I have had it, and probably you've also had it at some point of time. Usually, it's in the school age. We are standing in the assembly line when it's very hot, and it's a prolonged session, or during medical rounds when it's a 2 and 3 hours round. We are wearing apron and it's hot, humid. So syncope is very common. We probably have all suffered it. In geriatric age group, again, syncope needs to be investigated properly. Uh, Question is, what is the clinical presentation of syncope in patients with dementia? It's a variety of pictures may be there. In a person with dementia, they may be having slow reflexes. So just stumbling or while walking, it can cause they can slip, lose balance, and fall down. Uh, or it could be associated with hypersensitive carotid sinus syndrome. In some patients, there may be some form of autonomic dysfunction uh, if it is the patient has comorbidities like diabetes, or the dementia is related to some other neurological disease. That comes to my mind now. Hiren, do you have any other points to that, to add to that?
Yeah, I think, yeah, correct, sir. Orthostatic hypotension and autonomic dysfunction is maybe the main reason for syncope in especially dementia patients. Correct, sir.
Yeah. So I think that is the end of the questions. Kritika, I think we've addressed all of these. We are at 45 minutes, right on time. It's Friday evening, beginning of the weekend. Uh, so we can conclude at this point of time. I would say again, reiterate, these are challenging times. Please take care of yourself. Please take care of your family. Please take care of your significant others. And we'll all go through this COVID-19 pandemic, hopefully without any issues. Thank you very much. This was a fantastic session. Thank you, Dr. Hiren. Dr. Kritika, if you want, you can just conclude.
Thank you.